Welcome to UCSF Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Today, our topic is management of diabetes in 2023, updates and future directions for folks like me who trained 100 years ago. I don't know that there's any area in medicine that's harder to keep up with than all of the new medicines in diabetes. It's one where I sort of count on the house staff to know what's going on. But it strikes me that this is an area, probably more than any that I can think of, where the new developments in treatments, not only meds, but also devices, is probably more exciting and more transformative than in almost any other area of medicine. So we're very lucky to have a wonderful expert to explain what's going on to us. So the speaker today is Sarah Kim. Sarah's professor of medicine in the Division of Endocrinology and Metabolism based at ZSFG primarily, but also has a significant role over here at UCSF Health. Sarah went to college at UCSD, Tufts Medical School, UCLA for residency and fellowship. Luckily for us, came to UCSF for an advanced fellowship in diabetes and has stayed on our faculty. She runs the UCSF Diabetes Teaching Center, so she's a wonderful educator of both peers and patients, as well as an active clinician taking care of patients with diabetes, as well as taking care of patients with obesity and metabolic syndromes, both adults and pediatrics. And so thank you, Sarah, for coming over, and look forward to hearing what's new.
Hi. All right. Can you hear me? Okay. All right, so I'll be talking today about diabetes management in 2023, updates and future directions. Sort of the overall scope of the talk will be to review the foundations of diabetes management, which I think some of those foundations have not changed, and then sprinkle in some of the new and emerging therapies that are here or soon to come that continue to make diabetes treatment better and better. So the outline of my talk, I'm first going to talk about some diabetes background, again, review the foundations of diabetes management. I'm going to then touch upon some recently approved and emerging therapies in diabetes. I'm going to touch a little bit upon diabetes technology and what's evolved in that field. And then I'll finally give some updates in type 1 diabetes. Okay, so we'll just start a little bit with background to get a idea of the scope of diabetes in the United States. And this graph is the incidence of diabetes in the United States from 2000 to 2019. You can see that there was initially a rise in diabetes from 2000 to about 2010. And here in 2010, you see this interesting drop in the incidence of diabetes. And if you look carefully at who is getting diabetes and who is not, there was a sharp decline in new diabetes diagnosis upon people who self-identify as white. And in other racial groups, actually, the incidence continued to increase during that time. But the overall burden appears to be reducing in terms of incidence of diabetes. However, in terms of total prevalence of diabetes, we continue to grow. So people are living longer and longer with diabetes. And in 2000, about 1 in 10 US adults had diabetes. And that's currently up to 1 in 8 adults with diabetes. If you look at age groups, not a surprise, there's going to be a big differential there. So if you're between 18 and 44, the prevalence of diabetes is 1 in 20. That jumps up a lot in my age group, 45 to 64, where 1 in 5 of us have diabetes. And then astoundingly, in above age 65, 1 in 3 US adults have diabetes. So in terms of who touches the healthcare system, I mean, I see diabetes every day because that's my job, but I'm sure every one of you also sees diabetes every single day. So in terms of the diabetes breakdown in the United States, 90 and around the world, the majority of diabetes is type 2 diabetes at 91% here. 6% is type 1 diabetes, and 3% is other, either pancreatogenic diabetes or monogenic diabetes as examples. And there's been a lot of work examining the prevalences of diabetes among different self-identified racial groups. So I'll talk about NHANES data, which looks at diabetes prevalence by white, Hispanic, Black, Asian, or American Indian / Alaska Native populations. And you can see that there are significant differences in the prevalences of diabetes amongst these self-identified racial groups. But as we know, race categories are really insufficient in describing, I think, what we want to describe, which is something going on with the biology. And there's been some pioneering work. I have to give a shout out to some of our UCSF colleagues, Alka Kanaya, who spearheaded the Masala cohort, and she actually was acknowledged this year with the Kelly West Award in Diabetes Epidemiology at the American Diabetes Association Scientific Sessions for her landmark work in South Asian populations with type 2 diabetes, showing that even though they're categorized as quote unquote Asian, their rates of diabetes are 2 and 3 times that of other Asian groups. And this probably has to do with body composition specifically to that population. There's been additional work by Kaiser Permanente, Northern California, and Dean Schillinger of UCSF is also a part of this, the distance study, which also showed amongst disaggregated Asian subgroups that populations such as Filipino Americans have extremely high rates of type 2 diabetes compared to other Asian subgroups. So just illustrating that race as a general category has a lot of limitations. And I think we're trying to figure out biology and genetics. And we need to sort of evolve to be really careful about how we talk about race and diabetes prevalence. But the biology is different amongst different people, and that sort of helps to explain why some people get diabetes and why some people don't. It also is studies like this done by Diana Albach, our colleague at UCSF in endocrinology, is doing this work. She's an investigator of the IDO cohort study, which stands for Inflammation, Diabetes, Ethnicity, and Obesity, and under the mentorship of Sunil Kaliwad. And what she does is she collects participants of different self-identified racial groups, white, Latinx, and Asian, and does body composition analyses and then evaluation for insulin resistance, diabetes. She does fat biopsies. And she let me use some of her images from her study, which really illustrate some biological differences between individuals despite similar BMI. So this is a white individual with a BMI of 23, individual identifying as Hispanic with a BMI of 24, and an individual identifying as Asian with a BMI of 23. So by all accounts, their BMIs are very similar, and you would try to treat them similarly in terms of BMI and screening for comorbidities in your office, right? But if you were able to look closer, and she was able to do that and do a body composition analysis, you would see striking differences in the visceral adipose tissue of these individuals. So this individual here has a visceral adipose tissue mass of 200 grams. This person, similarly sized, has a visceral adipose tissue mass of more than double that. And then this one, same BMI, has triple the amount of visceral adipose tissue. And so this explains a lot of the variation in the risk of type 2 diabetes, despite sort of lean BMI or sort of disaggregated BMI versus type 2 diabetes risk, is because body composition actually matters more than total body mass. So these total body fat. So all of these participants actually equally had high total body fat, exceeding 35%. So it would put them actually in the obese category despite their lower BMI. But it was really the body fat distribution that mattered. So the person way on the left, Asian individual, actually has type 2 diabetes at the time of the body scan. The person in the middle goes on to develop type 2 diabetes 2 years after the body scan. And the person here with lowest visceral adipose tissue actually remains diabetes free. So just giving you sort of an understanding of sort of the pathophysiology of type 2 diabetes, how to approach your patient who may look like they have a normal BMI, but has metabolic dysfunction as evidenced on labs, And then also to consider that people on the higher end of BMI may actually have no metabolic consequences because it really depends on the distribution of the fat and what's going on with the fat rather than the total body weight. So limitations on not only racial descriptions, but also BMI to keep in mind. We're not going to throw those out and not use those categories, but we always have to take a step further and look at the person in front of you. Okay. So in terms of the staggering cost of diabetes in this country, just want to pause here and just share how much we are spending in terms of resources for diabetes today. 4,600 people will be told they have diabetes, adding to the 37 million Americans who already have diabetes, coming from a pool of 96 million people with pre-diabetes, which is 1 in 3 US adults. And we spend over $3 billion on diabetes, either through direct medical costs or loss of productivity. That's 1 in 5 healthcare dollars, 1 in 3 Medicare dollars. And a lot of the cost is actually borne by the patient themselves with out-of-pocket costs for things like medications and testing supplies. 15% of the cost of caring for diabetes is actually the medications and testing supplies, and patients bear a big part of that burden. So we're spending a lot. How are we doing? So on last count, about 2/3 of US adults meet their A1C goal. And it's an individualized A1C goal. It's not 7 for everyone. We let it be higher for people who are older, people who have some comorbidities. So but even with that adjustment, only 2/3 are meeting their A1C goal. 40% of people with diabetes have some form of CKD, and of people on dialysis, 40% have diabetes as the cause of their dialysis. 12% with diabetes have severe vision impairment or loss, and it remains as the number 7 cause of death in the United States. And unfortunately, as a pediatrician, I also have to share that the story is not quite over yet. And as we as adult providers are going to end up seeing this in our patient population as youth age into adult care. But there's a concerning rise in diabetes among youth, both a steady rise in type 1 diabetes and an even more rapid rise in type 2 diabetes among children. If you look at the distribution of diabetes amongst children of different identified racial groups, predominantly you think of type 1 diabetes in kids, and that's born mostly in children of white background. But in type 2 diabetes, it mirrors, the racial differences mirror that in adults. So we're seeing a lot of type 2 diabetes more heavily in our Hispanic youth, as well as our Black youth children. And unfortunately, for youth with type 2 diabetes, they actually fare worse than adults. And this was actually surprising to me when the Today Study Group started their prospective study of youth and type 2 diabetes. My own personal prediction was that children with type 2 diabetes would do okay. I mean, they're younger, they have younger bodies, and they have some type 2 diabetes. They might just stay really mild and we won't see complications, but actually the opposite was true. And so this study followed children who are diagnosed with type 2 diabetes. And you can see that over the several years of follow-up, their average or mean hemoglobin A1C was up in the 9 range. When you look at the distribution of A1Cs from the start of their diagnosis, many children had A1Cs of less than 6.5, which would be ideal for that age group. But by the end of a 10-year follow-up, only a quarter of children were meeting that A1C goal. And then even more concerning was that at 9 years follow-up, 50% of children with type 2 diabetes had some microvascular complications. So these kids are really young, right? They're now entering young adulthood and they already have probably more than one microvascular complication. And so just thinking about the problem with youth and diabetes and what that means for us adult providers, adopting children from pediatrics who've had type 2 diabetes already, they're going to have a more aggressive course of this disease. And then I have to say, this is old news as well, but that diabetes is preventable. It's actually a preventable disease, and that has been shown. And this is really important because 1 in 3 US adults have prediabetes, so they're at really high risk. And they're young. People with prediabetes, 30% of them are actually under the age of 45. And it's been well shown that diabetes is prevented with lifestyle changes. And so I'm just going to have to mention the diabetes prevention program, which had 3 arms. They had a placebo arm, they had a metformin arm, and they had an intensive lifestyle arm. And the intensive lifestyle arm was a year of intensive health coaching. The participants did lose weight, 7% of their baseline weight. The study happened to use a low-fat diet. You could use whatever macronutrient composition as long as the person's in a calorie deficit. And they had the participants engage in 150 minutes of moderately strenuous exercise per week. And the upshot is, as I think a lot of people have seen this slide, is that the lifestyle arm did the best. And so 60% reduction in the onset of diabetes. Second place was metformin. So metformin is still a viable treatment for prediabetes, but lifestyle is probably the best. There's actually 20-year follow-up of this particular study, and it still shows persistent protection against type 2 diabetes in the lifestyle arm, even though that arm gained all their weight back. So there's a legacy effect to the good things that you do to your body now that will trickle down many years later. So just when you're seeing your patients, they may not want to be part of an intensive coaching program, but they might be able to do some weight loss, on their own with their own programs, engage in some physical activity, and that has profound effects on their rate of getting chance of getting diabetes now and many, many, many years down the line. I have to give a shout out to Lisa Murphy, who's my chief at the General, and Audrey Tang, who's a nurse practitioner. They actually run a program for DPP, or Diabetes Prevention Program referrals, for any person in the safety net who is at risk. So if you have patients who are in the safety net, go to a clinic in the Department of Public Health, know that this is an option that's free of charge to them. Okay, so that's about lifestyle. But I know that we often will need to use medications to treat diabetes. So let's talk a little bit about medication approaches for type 2 diabetes. Now, back in 2009, which might be the last time you thought about outpatient diabetes medications, we had an algorithm, just going off what you said, an algorithm to think about diabetes medication that was quite more simple. It was based on evidence, though, strong evidence. One of the trials that informed the medication algorithm at the time was called the UKPDS, the United Kingdom Prospective Diabetes Study, that randomized people with newly diagnosed type 2 diabetes to tight control, which was A1C of 7, or A1C 7 goal, versus an A1C of about 8. And this is kind of before we knew like what A1C to aim for, right? So the A1C was relatively new. What A1C is good for us for people with diabetes. And the upshot is, what we now know is that having an A1C of 7 and not 8 lowers your chance of microvascular complications by 25%. So he's like, oh, A1C of 7, that's what we need to aim for. It trended towards lowering macrovascular events, but not statistically significant at the time of the trial. But subsequent follow-up data showed a reduction in mortality anywhere from 15 to 25%, as well as a reduction in reduction in MI and a reduction in all-cause mortality with intensive control. And it put the ranges there because it depended on what medications you were assigned to. People exposed to metformin had better mortality and MI outcomes. So based on this and other trials, the algorithm at the time was you'd start with lifestyle changes and metformin. And then if that did not sustain management of diabetes adequately, you added the sulfonylurea. And then if those two things didn't achieve your glycemic goals, then you went on to add basal insulin. Okay, so this was like how we approached type 2 diabetes. And we aimed for that A1C of less than or equal to 7 based on this data. Now let's talk a little bit about glycemic goals because that has changed as well. So this is data from the Diabetes Control and Complications trial, which is actually a type 1 trial. But what it shows here is what's seen in all diabetes trials, is that the rate of microvascular complications, this happens to be retinopathy, correlates very tightly with your A1C. right? So the lower the A1C, the lower your risk of microvascular complications. And there have been numerous studies that have shown this. Not only the UK-PDS, but the ACCORD and the ADVANCE and the VA diabetes trial, the lower you get the A1C, the better. There seems to be no limit to the lowness you can get that A1C to protect against microvascular complications. Macrovascular is a different story, and I'll explain why. But the trade-off with low A1C is hypoglycemia, and especially at a time when we are using sulfonylureas and basal insulin, right? Those are two hypoglycemic agents, and the lower you drive your A1C, the higher the chance you're going to over-medicate. It's just how it is, right? And so we settle upon hemoglobin A1C of 7 because that's where we balance the benefit of glycemic control and the risk of severe hypoglycemia being defined as hypoglycemia requiring the assistance of another person. But if we can eliminate hypoglycemia, then we can aim for a lower hemoglobin A1C. And so that's how you think about. That's one way to think about your patient's A1C goal, because it's individual. We have 7 as a general guide, but it may be less than 7 depending on your patient, their risk factors, and also what agents they're on. Can you safely achieve a lower hemoglobin A1C? Then I think you probably should, because the data shows that it's of benefit. Okay, so we've come away from this 3-box algorithm to this algorithm, which gives me a headache when I look at it, but it's the most recent medication algorithm from the ADA published. They do one every year. They revamp it every year and analyze the data. And it's like this thing that I can't even go through because it has too many words. But I'm going to give you sort of some big takeaways, and then we're going to simplify it, and I'm going to give you some highlights. So at the top, healthy lifestyle behaviors, diabetes self-management, and support. And not just saying this for my benefit as the director of the Diabetes Teaching Center, but really understanding diet and exercise is so important in your patients, and I'm sure you do it, and I'm sure you do it well. For those of you who don't have the time to sit and ask about your patient's diet and go through their exercise regime, there are people who are specialized in doing that, and it's a referral that you can make to the diabetes educators, and they do an amazing job at really combing through and sitting with the patient and optimizing healthy eating behaviors and exercise with their diabetes. What I will say that, over my experience with diabetes is that there's no way to medicate certain ways of eating. Like, there are many ways to have a healthy diabetes diet, but there are some ways that just are not compatible, and you can give them 10 different drugs and increase the dose to their utter max, but you will still not reach your A1C target unless some of these fundamental dietary practices are in place. So it's really important for optimal control. And then what's notably absent from the first line, which used to be present for years and years, is metformin. Metformin used to be that front line. It used to be the first line agent recommended before any other agents, and it's no longer there. It's down here, so it's kind of at the top, but it's alongside all of these other considerations. I have opinions about that, and I will kind of share a little bit of what I think about metformin and its role in type 2 diabetes, but just so you're aware of how the algorithm has changed. I think of the algorithm this way. My brain is too simple for that complicated algorithm. And so I have a simple algorithm in my head, and I start with metformin. I still think it's a really important drug, and I'm going to explain why in the next slide. So I start with metformin, and then I have these considerations of what additional risk factors does the person have. Okay, so if they have heart failure or if they have CKD, I'm looking at a sodium glucose transporter inhibitor, okay? If I have someone with ASCVD or high-risk ASCVD, I'm looking at a GLP-1 or I'm looking at an SGLT2 inhibitor with proven benefit. If anyone has a weight loss consideration, and that's kind of a trick question because a lot of people have weight loss considerations, I'm going to look at my incretin-based medications, okay? If there's absolutely no other considerations listed up here, then the next agent needed after metformin depends on how much A1C lowering, side effects, cost, et cetera. Okay, so this is kind of like my 5 categories in my brain, but I do consider metformin first. And I think lifestyle changes are important through every step. So I asked myself, is there a reason not to start with metformin? There's contraindications to metformin, so you don't use it in everybody, but there are a lot of compelling reasons to start with medication, the metformin as a medication, and it also includes cost. If you think about sort of the big scope of the cost of diabetes in this country. Metformin actually had its humble start as an herb used to treat diabetes 250 years ago, so talk about a track record. In 1920, scientists figure out that it was the guanidine derivative that was lowering glucose, and guanidine derivatives made at the time turned out to be toxic, so it wasn't used for diabetes. It wasn't until 1950 that metformin was actually formally developed in France, which is a biguanide, so two guanidines. That's why you call it a biguanide. It's our only biguanide. And I shared with you already the UK PDS data, which showed that decrease in mortality with metformin 10 years after the study ended. So the legacy effect with metformin, that's cardioprotective, and a lot of other sort of retrospective data that suggests that metformin has cardioprotective properties. Despite using it for so long, we are still figuring out how it works. There was a recent publication in January from PNAS showing yet another novel way that metformin lowers glucose. But the main thing that it does in cells is it activates something called AMP kinase. And AMP kinase, to make a long story short, is a glucose starvation signal, which is interesting, right? So in a state of diabetes, glucose is in excess, right? Glucose is in excess in diabetes. And metformin gives that opposite signal. The long and the short of it is that the downstream effect is that it reduces hepatic glucose output. And the liver's contribution to hyperglycemia in type 2 diabetes is very significant. And so metformin remains an excellent drug for glycemic control. And it has a really long safety record, which is great. But what's new and exciting is not metformin, it's these incretin analogs. And so I'm going to take a little bit of time to go through them. There are several at our disposal these days, if you can get them. The daily liraglutide, so once daily injection liraglutide or Victoza, weekly exenatide extended release, fixed at 2 milligrams. There's dulaglutide, Trulicity, which has 4 different doses that you titrate up to if needed. There's the Ozempic that can go up to 2 milligrams weekly. Ribelsis is the only non-injectable GLP-1. It's oral semaglutide, which you can use as well. And then the newest incretin-based medication is tirzepatide. And it's unique in its mechanism of action, and I'm going to go through that as well. There are, 6 different doses that you would titrate up to. I'm not going to talk a lot about the practicalities of prescribing GLP-1s, but we do a slower titration of the medication really based on the side effect, because it does cause nausea in a lot of people. And if you do too rapid of a titration, they're going to have more of that nausea. Okay, so what are these drugs doing? So you digest your carbohydrate, as you are now, in your small intestine that gets broken down into glucose, okay? And then the small intestine absorbs that glucose via SGLT1, which becomes important in a couple slides, but it absorbs that glucose. And then there are enteroendocrine cells that also sense the glucose. And in response, they secrete incretin hormones. One of these is GIP, and one of these is GLP-1, okay? So these incretins go to many places, but of most importance, they go to the beta cell here. And the way they work is by enhancing intracellular signaling inside the beta cell to improve glucose-mediated insulin release. So they actually increase cyclic AMP. And cyclic AMP is important downstream signal for the beta cell to respond to glucose and then secrete insulin. So it enhances the beta cell's activity. It's not like a sulfonylurea. Sulfonylurea is kind of just force the beta cell to make more insulin, sort of independent of the glucose levels. But the GLP-1 works with the glucose levels to make the insulin secretion more appropriate. So there are GLP receptors on many tissues, including the pancreatic beta cell, which causes the anti-diabetic effect. The insulin released from the beta cell then has an anti-glucagon effect, right? Because of the paracrine effect from the beta cell to the alpha cell, diminishing the glucagon released from the alpha cell. So it has anti-glucagon effect. There are GLP-1 receptors in the hypothalamus and the brainstem, which control satiety and hunger. So it has a satiety effect, which makes it a weight loss medication. There are GLP-1 receptors in vagal neurons, which contribute to gastric slowing. So the nausea and the gastroparesis that's seen in GLP-1s is due to GLP-1 receptor activity at the vagal neuron. Now, this effect is supposed to tachyphylax. So after the person is on the medication for about 6 to 8 weeks, the pharmaceutical companies say that should get better. So is not a persistent side effect, theoretically. So I tell patients that if they have nausea in the beginning and it's not too much, if they stick with it, it may go away over time, or it should go away over time. There are GLP-1 receptors on pancreatic acinar cells, so those cells that make the digestive enzymes, and hence the perpetual debate as to whether GLP-1s cause pancreatitis or associated with pancreatic cancer. The data is frustratingly non-conclusive a lot of the time, so we don't really know what's the exact relationship between GLP-1s and pancreatitis. Suffice to say, in the endocrine practice, if you have someone with ongoing risk of pancreatitis, they're going to probably have pancreatitis again for whatever their risk factors. We don't prescribe GLP-1s because you just don't know, is the next bout of pancreatitis because you gave them the GLP-1 or because they have just pancreatitis again. That said, if a person has a completely resolved cause of pancreatitis, like gallstone pancreatitis or maybe hypertriglyceridemia, and that is resolved and controlled, you could probably safely trial GLP-1. So there are GLP-1 receptors on the sinoatrial node, which probably cause its side effect of tachycardia. I don't know if people have noticed that patients develop tachycardia on GLP-1 as a side effect, so you do want to keep an eye on that. And then there are GLP-1 receptors on vascular smooth muscle. There's some concern that there are GLP-1 receptors on malignant medullary thyroid cells. And there were, in rodent models, there was medullary thyroid carcinoma on exposure to GLP-1. Medullary thyroid carcinoma, I'll remind you, is very rare. So it's not papillary thyroid carcinoma, which is like over 90% of thyroid cancers. It's a small portion of thyroid cancers that are rare and also pretty aggressive. So someone who has medullary thyroid carcinoma is going to have a more sort of progressive course in their cancer. So we don't use it in anyone who has medullary thyroid cancer. It also can be familial, so you wouldn't want to give it to someone who has a family member with medullary thyroid cancer. And if you ever encounter someone with MEN2, I think I have like one encounter of MEN2. I think Paul Fitzgerald probably has many more of him. He's shaking his head. No, not much MEN2. But, as you remember from medical school, that's associated with medullary thyroid carcinoma, so you wouldn't want to give it in that either. So a little bit of caution there. I think a lot more data to be gathered. And then I just want to finish with a little bit of recent news about GLP-1 agonists. I think the biggest news is they've been hard to obtain, very hard to obtain. This is I took a quote from, I think, Forbes that said the CEO of Novo Nordisk, shortage of weight loss drugs could persist for some years. It was very disappointing. It was supposed to get better in September. It's been September, and I don't think it's any better. So we might be several months out from having adequate supply of GLP-1. People are resorting to compounded semaglutide. I don't know what compounded semaglutide is. I would never recommend it. You can't get semaglutide like from an animal, like you can like thyroid hormone. So highly discourage any pursuit of compounded semaglutide by your patients. And then a bit more relevant to medical practice here is a recent a consensus-based guidance put out by the American Society of Anesthesiologists on the preoperative management of patients on GLP-1. And so they put out this guidance based on 2 retrospective cohort studies and 1 case report, which showed no serious harm, but did show retained gastric contents in people who are undergoing planned procedures and who were on a GLP-1, because it does cause that gastric slowing. So their recommendation was to then stop the daily GLP-1 the day prior, which kind of makes sense anyway, and then to stop the weekly GLP-1 the week prior to a procedure. And so I don't think it's quite settled how we're going to manage this on a very sort of a systemic level in terms of pre-op practices, but just so this is on your radar, this concern for people undergoing anesthesia on GLP-1 agonists. Okay, so let's talk a little bit about the newest GLP-1. It's actually a GLP-1 GIP, tirzepatide. So this is the amino acid structure of GLP-1. This is GIP. And then this is tirzepatide. Tirzepatide is actually one molecule that agonizes two receptors, so both receptors. GIP is glucose-dependent insulinotropic polypeptide. It's secreted by more proximally in the small intestine than GLP-1. It helps to stimulate downstream GLP-1 release. It enhances insulin release, as I showed you at the beta cell. It also promotes satiety at the central level. So it's really great addition for weight loss. And it doesn't cause nausea. So that's a really nice feature of GIP. If you want to develop a better diabetes/weight loss medication that doesn't have more side effect. So you can have more of the weight loss effect. You can have more of the insulin secretion effect without having to add more nausea. And so tirzepatide agonizes both. This is data just from one study looking at tirzepatide compared to semaglutide 1 milligram weekly, so kind of a middle dose of semaglutide, and its effect on A1C and weight. The first graphs on the left are A1C. So you can see that with semaglutide, you're lowering A1C about 1.8 compared to tirzepatide, which is over 2. And then you can see these A1Cs in the trial, I mean, getting really far down into the 6 and 5s, right? We're able to get these really low A1Cs without the disadvantage of hypoglycemia. In terms of weight loss, pretty impressive. The semaglutide, you lost about 6% body weight. Here, we'll look at this one here. Whereas with tirzepatide, you're down into 13% range. So not quite bariatric surgery in this trial, but pretty impressive. And then down in the pipeline is a drug called retatrutide. It's still in phase 2 clinical trials, but it is a fatty acid acylated peptide that is engineered from a GIP backbone, dosed weekly, and it activates actually 3 receptors. So GLP-1 and GIP, sort of like tirzepatide, but then it also activates glucagon, which you might will hopefully be like, why glucagon as an anti-diabetes drug, right? Because glucagon does the opposite of insulin. It raises glucose. And why would you give a glucose activator in someone with diabetes? And I think it has to do with sort of the preferential stimulation of the various receptors. So it actually stimulates GIP more than GLP-1, and probably both of those more than glucagon. But why glucagon? So glucagon actually has turned out also has a satiety effect. So we're still looking at how much weight loss we can get out of these medications. So it has a satiety effect. And it also has an interesting effect in increasing energy expenditure, which is a kind of a newer mechanism, right, for a weight loss medication, right? So far, we've had one trick, which is to suppress appetite with all of the medications that we have, that they're all appetite suppressants. But this would be sort of the first one to also tackle the energy expenditure piece of weight loss, which really hasn't successfully been done before. And we know that there are metabolic adaptations to weight loss, such as slowing down of the metabolism, which, I don't know, may theoretically be addressed by medications that increase energy expenditure. So in a phase 2 clinical trial against dulaglutide, it lowered A1C 2%, weight loss was 17 kilos, and 40% achieved an A1C greater than or equal to 20% on this medication. So on par with sort of the lower end of bariatric surgery. Very little nausea. So another plus when you can minimize that GLP-1 effect and maximize some of the other incretin effects. And as I said, phase 3 clinical trials are just beginning. So we'll see in the next couple of years how this pans out. All right, so let's shift over to sodium glucose cotransporters. There are now 6 that you can prescribe. I only have heard of the first 3, honestly, before I was preparing this talk. But there are these competitor drugs out there that you might run into. They all have, or nearly all, have an indication in lowering glucose in type 2 diabetes. But as the clinical trials have shown, they have cardiovascular protection, as well as protection of kidney disease progression in some of these SGLT2 inhibitors. So much so that some SGLT2 inhibitors have kidney indication or CHF indication independent of type 2 diabetes. So you don't even have to have diabetes. You could have either CHF or you could have CKD, and you may be warranted to take a sodium glucose transporter inhibitor. I think this is just an interesting development, right, in the development of medications for type 2 diabetes. We wouldn't have known this, right, until the FDA mandated that all diabetes drugs who come to FDA needed to do a cardiovascular safety trial. And this happened after this concern for rosiglitazone that might have been causing myocardial infarction. And whether that was true or not sure, but that caused this mandate to have cardiovascular safety trials. And because of that, we were able to see that actually some of these new agents were superior, not only not inferior, not causing cardiovascular harm, but actually superior. And so then we've kind of opened up this whole realm of cardiovascular improvement with diabetes drugs because of that history with rosiglitazone. So I think it's all kind of pretty fascinating. Sotagliflozin, I'll just point out and go through a little bit, is the newest SGLT inhibitor, and it's unique in that it actually is an SGLT2 and SGLT1 inhibitor. Okay, so SGLT2 inhibits glucose reabsorption in the kidney. SGLT1 inhibits glucose absorption in the kidney, but also in the small intestine. Okay, so as you're trying to digest glucose, you want to absorb it into the systemic circulation, it goes through SGLT1, and sotagliflozin will block that transporter. And so the glucose will theoretically go unabsorbed down the GI tract. It might have, therefore, downstream effect in enhancing GLP-1 release. And then you just don't absorb the glucose. So it has sort of an anti-glycemic effect. It's actually been around for a while. It was approved in 2019 for the treatment of type 1 diabetes. Don't ever use it in type 1 diabetes, but you can do that in Europe, but you're not going to do it in the United States. And I think you guys know why, because of the GKA. It lowers A1C about on par to other SGLT2 inhibitors, which is about 0.5 percentage point. Improves weight a little bit, improves blood pressure, probably because of its diuretic effect, and causes DKA. So in type 1 studies in Europe, there was a 3% DKA rate. So yes, don't give it to people in type 1 diabetes with type 1 diabetes. But it's had some promising effects in type 2 diabetes. So this is their cardiovascular outcomes trial. Type 2 diabetes and CKD and CV risk were the participants. Their outcome was MACE and first occurrence of CV death or CHF hospitalization, which was reduced by about 16% in this graph. A1C lowered a little bit, 0.5 percentage point compared to placebo. What were the adverse events? Diarrhea, as you might imagine, was something that impairs glucose absorption in the small intestine. A little bit more DKA compared to placebo. GU mycotic infections, which we see with this class of medication, and volume depletion as well, which we see in this population of drugs. And then they had a second trial that was interesting, was sotagliflozin in people with type 2 diabetes who were hospitalized for congestive heart failure. And the drug was started either during the hospitalization for CHF or within 3 days of discharge for CHF. And their endpoint was hospitalization or urgent care visit for CHF exacerbation within the time after discharge, which it was able to reduce by 35%. Cardiovascular death actually was not improved with the drug, but it was therefore approved as a drug in May of 2023 for a CHF indication with or without diabetes. Okay. So where do these new drugs fit in the algorithm? I would think of sotagliflozin and under heart failure, of course, and then tirzepatide under the weight loss consideration. Since this cardiovascular trial is not completed, we'll yet to see whether it will have that indication as well. Okay, and then coming soon, hopefully, is insulin icodec. I think it's under FDA review. Insulin icodec is actually, this is the insulin molecule, and insulin icodec is insulin attached to a fatty acid chain. Because of the fatty acid chain, it tightly binds to albumin and has a really long half-life. So it lasts 1 week. You dose this basal insulin every week. In a clinical trial against glargine, 10 units daily versus insulin icodec, 70 units weekly. So you just multiply the dose by 7 and give it once a week, which is kind of frightening to me, but apparently did okay. Here's the clinical trial outcome. This is A1C lowering with glargine versus insulin icodec. About the same. This is CGM findings, which show maybe a little bit more time in range with icodec, and similar A1C achievement with once weekly basal insulin compared to daily basal insulin. So I'm personally looking forward to getting my hands on that. Okay, so I just want to give some updates now, switching gears to monitoring, continuous glucose monitors. Right now, very popular amongst type 2 diabetes is the Libre. It is a continuous monitoring device that requires Q8-hour scanning. It has a reader that you can use, or you can use your smartphone. The newer version is Libre 3, which actually doesn't require scanning. It just takes the glucose measurement automatically every minute and sends data to either your cell phone or your reader. On the other side, we have another competitor would be Dexcom. Dexcom G6 is popular amongst people with type 1 diabetes because it can integrate with current pumps and participate in automated insulin delivery. And then the newest generation of Dexcom is the G7. It's a little bit smaller, has fewer parts. It's not really integrating with pumps just yet, but that should be happening soon. If you're curious to know if it helps in type 2 diabetes, some moderately sized randomized controlled trials showed that in type 2 diabetes, it lowers A1C about 0.5 percentage point compared to traditional finger sticks. A little bit more about them. So they're factory calibrated, meaning you don't need to do a blood calibration to have accuracy. The manufacturers account for some decay in every day of wear. So at 10 days of Dexcom or 14 days of the Libre, they kind of self-expire, can't use them anymore. They're not accurate enough. The Libre is worn in the back of the arm. The Dexcom is worn on the abdomen or the back of the arm. If you wanted to know more specifically what these devices are doing, there's a sensor that enters under the skin. It's in the interstitial fluid. It senses interstitial glucose that's converted by the computer into glucose, a glucose number, which is then transmitted to either your smartphone or to the reader. So updates with that is that Medicare has expanded coverage for these devices in people who are taking insulin or people who have difficulty with hypoglycemia despite attempts to modify their diabetes treatment plan. Medicare also requires Q6 month visits to document adherence to the device. If you're going to use the device, it's good to be familiar with the readout. So if you download one of these devices, you get a report. What does the report look like? So this is a patient of mine, lifelong diabetes on basal bolus insulin, thought to be type 1, is probably more of a type 2. So her report shows that she's using CGM 97% of the time. That's important because it's sometimes way less than that, and then the data is not as accurate. It spits out an average glucose. Hers was 150. Her estimated A1C or GMI was 6.9%. And her glucose variability, which is a coefficient of variation, was 43. That was a little high. Arbitrarily, we kind of want that less than 35%. That sort of describes how much she's fluctuating high and low. Then you have this rainbow graph of time in range. So this green is time in range 70 to 180. So 57% for her. Ideal would be about 70%. And the other metric to kind of attack here is the lows. So I think this is the biggest benefit of CGM, is that it shows you where people are going low, and she's going low a lot. So 11% of the time, we want that, generally under 3% or so. It'll give you a 24-hour sort of shot of all the glucoses over the 14 days to allow you to see where the highs and lows are happening. And so for her, the lows are happening overnight. Gives you a calendar day. Every day has an average glucose. Every day has the number of times she's scanning and number of hypoglycemic events. And then when you look at the day-to-day, see the tracings are here, 12 a.m. to 12 a.m. Every time she scans, there's a number. Every time she eats, she enters that she's eating, and it puts an apple there. She could even write in there the meal or the number of carbs if she wanted to. And then every injection thing is when she's injected short-acting insulin or long-acting insulin. And again, if she wanted to, she could write down like the units. And you can see clearly where the lows are happening and that she needed to lower her basal insulin. Some suboptimal uses of CGM, just to point out, if you have the Libre 2 that requires the Q8-hour scanning and you don't scan Q8 hours, this is what you get. So you get a big gap in the data. This person's not knowing that they need to scan at nighttime in order to get all that daytime data retrospectively captured, and will be reflected in the report as this big hole. So good counseling to be done with these devices. And if you're going to have more than a few patients on this, you're going to want a clinic account. I have a clinic account. It has 2 practices of mine, ZSFG and UCSF, where all of my patients on Libre are stored. I could look at their data. If they're uploading to their phone, I could look at it in real time. So it's really nice, nice technology. Just wanted to share Dexcom Clarity is also an option for people, often more used in type 1, but can be used in type 2. This is my patient with type 2 diabetes, kind of struggling with high glucose, as you can see here, is afraid of lows and is kind of snacks all the time. I saw him this month and his glucoses were so amazing. I was like, oh, what happened? Wow, the glucoses are not as high as before. What's going on? The patient, I saw the ophthalmologist and she's like, no, your glucoses are too high. You need to get those down. She scared me. I got my glucoses down. I was like, that's good. It takes a village, to treat diabetes. This is like one reason to send your patient to the ophthalmologist. All right. But these devices have allowed for something called automated insulin delivery. So the sensor is able to give information to the insulin delivery system, which is the pump, and able to adjust as needed and protect from highs and lows. I won't go this in too much detail, but this is what a printout would look like if you downloaded an automated insulin delivery device. Not only do you get CGM data, but you get sort of the insulin dosing as well. There are many devices out there. The most recent is the bionic pancreas, so to speak. And I'm going to go through that a little bit. It's very interesting in the fact that for all of these pumps, you need to put in settings, and that's kind of the endocrinologist's job. We figure out the carb ratios and the correction factors and the basal rates. But for this one, you only enter the patient's weight, which is kind of interesting. So all of you in this room could start someone. I wouldn't encourage that, but you could do that because you, as well as I, know the patient's weight, and that's all the information that the pump wants. It doesn't want any other information. It wants to figure it out for itself. And then the person wearing this bionic pancreas does not actually enter carbs. It doesn't want to know that. It wants to know whether you're having your usual meal, a bigger than usual meal, or a smaller than usual meal. That's all it wants to know. And it wants to figure out the rest on its own. It's kind of scary, but diabetologists like to have control. And so this is like a test of how much control we can let go of. So this is just some clinical data of the performance of this device. And it's just kind of hard to look at this data, but this is time in range on a CGM. The higher, the better. The red is like the person's baseline care, whatever it was, whether it was, insulin injections or a non-automated pump or an automated pump of a different brand. And when they were put on this so-called bionic pancreas, their time in range increased over the study weeks, and their mean glucose is decreased over the study weeks. There was a dramatic improvement in some people's A1Cs, especially if they started really high. And if you look at the hour-to-hour profile of the bionic pancreas, which is in blue, it did outperform their standard treatment, which was in red. So it's just a new development in type 1 diabetes care. I want to explain how I think about insulin pumps, because I think that has also changed recently. I think of insulin pumps like cars. And so insulin injections, to me, are like a sedan. They're like perfectly fine. They'll get you from point A to point B. They'll give you insulin. They'll keep you out of trouble. And if you know how to use them, you can function quite well. We used to think of non-automated insulin pumps like sports cars, right? They were kind of like a fancy pen. They delivered insulin, and they delivered insulin in more nuanced ways. But if you were not a sophisticated driver, you really couldn't take advantage of the features. And you might actually run into problems if you didn't know how to troubleshoot such a sophisticated vehicle. And so we kept it away from people who struggled with diabetes self-management because we thought of it as risky, right? So we didn't give pumps to people who struggled with sort of the basics. But now I think pumps have really changed. I think of them more as like self-driving cars, right? So like, you might actually want to give a pump to someone who's struggling, someone who has a harder time with carb counting, someone who's not able to do all of those daily tasks for type 1 management that requires so much time and attention. Or maybe they're just tired of all the time and attention that they have to pay to all of this stuff, and an automated delivery system can reduce that cognitive burden. So who we think about as appropriate for pumps is also changing as we speak, and for the better. Okay, so finally, I'm going to go way like in a different direction and talk about teplizumab, which is newly approved for type 1 diabetes prevention. A lot of work done by Jeff Bluestone and colleagues have shown that type 1 diabetes is an autoimmune disease mediated by the T cell. Teplizumab is a monoclonal anti-3 antibody that blocks autoreactive T cells and therefore protects against beta cell destruction. It promotes immune tolerance in these individuals. It's an IV treatment given over 14 days with relatively small adverse reactions and well tolerated. I'm going to share with you one of the pivotal trials that showed protection against type 1 diabetes in people at high risk. So those with high risk at type 1 diabetes received either teplizumab or placebo. And by the end of the 60-month follow-up, less of the teplizumab arm went on to develop type 1 diabetes. The key to giving teplizumab is to identify who's an appropriate candidate. And it's kind of tricky because you need to find someone in stage 2 diabetes, which is someone who has antibodies against pancreatic antigens, and also some level of dysglycemia, so impaired fasting glucose or impaired glucose tolerance or pre-diabetes by A1C, but not overt diabetes. And so it's in this sort of sweet spot that people with teplizumab can receive treatment. So if you have a primary relative, a first-degree relative, or even a second-degree relative with type 1 diabetes and you want to be screened for risk, you can actually go to TrialNet UCSF, where you can get antibody testing and glucose testing free of charge. So just want to shout out to Zoe Quant, who's leading that effort in our division. Okay, so I went a little bit over time, but wrapping up here, we talked about the disease burden of diabetes in the US. We talked about current treatment approaches, good old metformin, which I still use all the time, and the new tirzepatide and sotagliflozin and their unique roles. We talked about continuous glucose monitoring becoming more widely available in people with type 2 diabetes, automated insulin delivery, that's kind of like a self-driving car at this point, and then the exciting development of type 1 prevention with teplizumab. And I'll end here, and I'm happy to take questions.
That was fabulous. It's too bad nothing's changed in the field over the last few years. Let me start with one question, then we'll open it up and we'll go a couple minutes over. We're running a little bit late. I was intrigued by that sort of confluence of the studies that look at the Ozempics of the world, that they're both treating your diabetes and lowering your weight. And that study that showed that if you lowered someone's weight for a while, you had long-term effects. So since a lot of people will probably not stay on those meds forever, do you think we're going to find, or maybe we know this already, whether short-term weight loss associated with better control for a short period of time will have durable effects? Or do you think once people stop these meds, they will revert? Is that too hard a question? You want an easier question?
All right. No. I'll try. Okay, so how do I answer that question? So I think with the DPP, I sort of overgeneralized it a little bit. I mean, the people lost weight with diet and exercise, and they probably maintained a lot of those habits throughout, even though the weight comes back, right? So you can still be having different ways of eating, healthier food choices, and exercise, which has a huge impact on mortality and insulin sensitivity, even though your weight comes back. So the DPP is a little bit of a special story. I will say that with any weight loss intervention, there's always some weight regain and a plateau up to a higher weight than what you started in terms of weight loss, even in bariatric surgery. But there's very clear science that bariatric surgery reduces mortality. So, there is a long-term effect, even though weight doesn't stay perfectly low all the time, and there is a regain. Now, the question of whether you can do short-term GLP-1 therapy, for example, and expect to have legacy effect in the future is I don't know. Yeah, and especially rapid weight cycling has been suggested to be unhealthy. So I certainly wouldn't recommend that.
Great. Questions here? Lakshmi, do you have any?
Yeah,
Go.
a bunch of people from the audience, 150 viewers, are wondering about GLP's impact on the gut microbiome, mental health, a little bit more about gastroparesis, and then common drug interactions to watch out for.
Take the easier, whatever ones you like.
So I know, big bolus. So there's not that many drug interactions with GLP-1s, I have to say, but when you're combining it with hypoglycemic agents, you want to be careful to taper off some of those or reduce the doses of hypoglycemic agents, so not to bring out more hypoglycemia when you add the GLP-1. Yeah.
Something that you hinted at, but didn't you sort of mentioned the reason metformin became the rage was it didn't cause hypoglycemia the way the sulfonylureas. Do these meds, either of those two new classes, cause hypoglycemia?
No, I should have made that pretty clear. That GLP-1s do not, incretins don't, and SGLT2s don't as well. Yeah.
Okay.
Yeah.
Gut microbiome?
I'm honestly not as up on that data. Yeah.
Good. Any other questions, people? Do you have another question?
I think from a policy perspective, because you're med peds, one viewer is asking about the recommendation about therapy for kids, over and under the age of 12 with obesity. And, what do we think about the policy implication of these drugs for teens and preteens?
So we do use them in our clinic. We use when we can get our hands on them, semaglutide for youth. I have to say that the youth that we see in obesity clinic have very high BMIs. They have NASH, they have prediabetes, they have hypertension. And so we're giving them for a really good reason. We're not just trying to make thin kids. We're trying to protect people against really serious comorbidity. So in that sense, I feel fully justified in giving an expensive drug, especially to a child who's probably going to struggle with their weight all of their lives. The problem is the cost, but that's the problem. And I don't think the problem is I feel confronted with this question of like, well, is it worth it? I'm like, well, the only reason it isn't worth it is because of the cost. And so I think that's just, can we fix that problem? And then I don't have to answer that question anymore. Yeah.
The downstream costs that you may be saving in terms of all the comorbidities of diabetes.
Right.
Are you thinking about bariatric surgery differently now that these drugs are available in an obese, let's say younger obese person with diabetes?
Yeah, I try to explain to all patients who I'm starting on this medication, especially for weight loss, that they are probably long-term in the sense that if you stop the medication, the data clearly shows some weight regain. Not that it's impossible to maintain weight loss, but it's harder because you get rid of that appetite suppression. So actually in a younger person, I counsel them a bit more about bariatric surgery because it's not just a one and done, but like it is kind of a one and done where you do a procedure and then it has many, many years of benefit afterwards, whereas a medication you need to take chronically. So it's a discussion I have with patients, and people have all kinds of different feelings about the two options.
But in terms of people stopping it, it's either it's cost or volitional. It's not that you have to stop it. Theoretically, you could take it forever.
Theoretically, I mean, the class of medication has been out for about 15 years. So I think it's fairly safe, but I guess time will tell.
Yeah. Okay. We need to quit. Thank you so much. It was terrific. Really appreciate it.